I decided to show you my alphabet of sepsis. That's just an overview, and you can read the paper in the journal issue. That's just a personal view without any constraint. I like meta-analysis, I like systematic review, but sometimes we are a little bit tired about this, and we need to give you our personal view without any consensus. That's my choice. I don't know if it's the best choice, but I just go through the alphabet and gave for each letter my view in relation with sepsis. So we start with A and B, C, D, and so with E, and that's for me the first letter is antibiotics, and the talk of Mike Niederman was so excellent. I have nothing to add, and this perfect. And just for antibiotics, which is really important, that they are the key in sepsis. But of course, there is an overuse because not all patients treated for suspected sepsis have sepsis, and we know now, and there is some good data from Ree and collaborators showing that too broad spectrum, too large use of antibiotic, overuse of antibiotic lead to resistance emergence and lead to side effects. So be careful with antibiotics. We need them. They save the life of your patients. It should be administered early in the course of the disease, 1 hour, and very early in septic shock in the first 5 hours with sepsis. But the balance between an overuse and the wise use of them is particularly important. So I will go very fast on B. B for me is, there is a lot of letter, but breathing is probably important and probably should be viewed with more attention, especially in the ward patient, in which the monitoring of breathing can be important. But I don't stay on that. So C is circulation. Circulation is really the cornerstone differentiating sepsis and septic shock. And as you all know, the definition of septic shock is sepsis associated with a vascular failure. So circulation is very important. And if you don't understand very well the principle of circulation in physiology and in all patients, you cannot treat adequately your patient. So circulation is especially important if you want to treat patients with sepsis and septic shock. And we should also keep in mind that microcirculation is probably impaired in most patients with sepsis before septic shock occurs. So for D, I will use dysfunction, but I could speak about de-escalation because that was my first topic in my professional life. But dysfunction, once again, is included in the definition of septic shock and sepsis, and dysfunction is really something important for the intensivist. We should look at that in our patient. We should look at that from a systematic fashion, using perhaps checklist or something like this. But every day we should detect dysfunction of organs in our patient. However, I don't like the principle of multiple organ dysfunction syndrome as cause of death, because for me, it's not a cause of death, but a kind of picture of death. And under the multiple organ dysfunction, there is all the time a disease that we need to identify. E is early. We already talked about early in the previous talk, early is very important in sepsis. The early identification, the early diagnosis of sepsis is critical for the outcome of patient. The early administration of antibiotics and also the early source control, that's really important in terms of outcome. And there is different score like the QSOFA or strategy using a point of care ultrasound, for example, that can facilitate an early diagnosis at the bedside, but really early should be kept in mind. However, the word early is really very often used, but in my practice, I prefer as soon as possible. And when I have a patient with sepsis, I give the antibiotics as soon as possible, and I correct the organ dysfunction as soon as possible. Not in 1 hour, not in 3 hours, as soon as possible is really important. I use F for fever. And fever is really a challenge in my professional life when I run in the ICU. Fever is really the attractive sign for resident. And if patient has no fever, he has no sepsis, and a patient with fever has sepsis. And in practice, it's wrong. It's wrong in 50% of cases. And so fever is probably overview in the medical world. We should keep in mind that patients with hypothermia, for example, may have worse outcomes than patients with fever. And finally, we don't know if we need to treat fever in the non-brain injured patient in ICU. And the experimental data favor not to treat fever if there is no brain injury. So fever is critical symptoms, but this sign can lead to treatment in excess, and we should be really more prudent, more careful with this clinical sign. G for gas exchange. Gas exchange is really important.
Marc, I'm a little concerned about the time, you know, because we are only at G, and you are approaching the end of your summary.
Okay,
here.
I accelerate, no problem. So G, H for hydrocortisone, which is still a controversial issue in septic shock. I for intra-abdominal infection, and I think we miss a lot of patients with intra-abdominal infection, and very often we are delayed in our management of these patients. G as junior, which I think that the education of junior about sepsis is critical. It's critical. K for kidney, because acute kidney injury is really a strong predictor of long-term outcome in these patients. And for lactate, lactate is really a wonderful biomarker for patients. There is some wrong positive, some false positive, some false negative, but most of time it's really a very relevant biomarker. And all-in-one serum lactate should be remeasured in the slab test due in clinical practice. And for monitoring, it's important to use a continuous monitoring of cardiac output, even if it's under debate. For me, that's my personal view. And for nitric oxide, which is the mediator responsible for vasodilation, and that's really important to know this mediator, to understand the principle of vasodilation in our patient. For oxygen, and we all know how oxygen is important in patients with shock and those with septic shock especially. And it's important to keep in mind that elevated values of oxygen, as well as oxygen central venous saturation or PaO2, are associated with impaired outcomes. So we need to balance the benefit and and the arm of oxygen in our patients. P for pneumonia. Pneumonia is really important. It's the first cause of infection in ICU. It's framed by guidelines, but I really think that in clinical practice, there is an overdiagnosis of pneumonia, and sometimes that can result in mistake and in wrong treatment and in delay in the management of other infections. So be careful. Pneumonia is very challenging as diagnosis, and try to keep it as last diagnostic after eliminating other source of infection. Q for Q so far. I don't know what you think about that. That was a good idea. In practice, I don't feel it's really useful at the bedside in most wards and in emergency department. I don't know, but I don't use a lot in clinical practice, and perhaps that has been a little bit disappointing. For relatives, that should be considered in patients with sepsis, because it's difficult syndrome to understand, and a good communication requires skills and relies on efficient training. And we have to communicate on sepsis with relatives. S for source control is critical. Any delay, source control, if feasible, is associated with impaired outcomes. So be really sure of your source control in your patient in the first 6 hours. Trauma, I will fly on that, but trauma is another inflammatory state which shares a lot of characteristics with sepsis, and that's really a good example and a good model for sepsis, like the use of whole body CT scan. Like ultrasound, and I think that ultrasound are really the fifth pillar of the clinical examination today, and they should be used largely in ICU for the source identification and for the organ dysfunction to evaluate each organ. That's really convenient at the bedside. V for vasopressors. You all know that norepinephrine should be the first choice, that vasopressin is today probably the best choice as second line. That's other vasopressors are emerging, and that's probably we need to use a multimodal approach with those drugs. W for withholding and withdrawal of life-sustaining therapy. That's very important for me, that resuscitation should not be an end in itself, that the quality of life after ICU should always be discussed with the patient and with the relative, and that we should keep that in mind, and especially in those patients, sometimes I'm embarrassed with their outcomes. X for Xigris, in fact, which was a promising drug with anticoagulant and anti-inflammatory properties. Unfortunately, that don't work in several RCTs. Y for yeast. Yeast are the second agent of infection, Candida and Aspergillus. And I think that all the management about yeast are really complex, and we need something very simple to determine the best antifungal agent we need to choose at the bedside. And Z for zero and respiratory pressures, which is never indicated in our mechanically ventilated patient. But the first goal with ventilator setting is not to harm the patient. So we need to have a very personalized approach and not a kind of protocolized approach. And that's really important. So thank you for your attention. That was my personal choice. Think about your personal choice, and I'm ready to respond to your questions.